are not recommended to have progesterone. But the important thing is that they still emphasize shared decision making that the patients must know. Now, NICE guidelines published 2015, revised 2022, actually also emphasizes the fact that offer a choice of prophylactic vaginal progesterone or prophylactic cervical sacrilege to women who have both history of spontaneous preterm birth, 34 weeks, up to 34 weeks, or loss from 16 weeks of pregnancy onwards, and results from a transvaginal ultrasound that's done between 16 and 24 weeks that shows cervical length is less than 2.5 centimeters. Discuss the risks and benefits of the guideline. It says the same thing, apart from the fact that it says that that's insufficient evidence for effectiveness of injectable progesterone. Now, talking about combined vaginal progesterone and cervical sacrilege in the prevention of preterm birth, a systematic review. This is again 2023. The combined treatment of cervical sacrilege and vaginal progesterone could potentially result in greater reduction of preterm birth compared to either cervical sacrilege alone or using the progesterone alone. So what's the call to action? Individualized care. Assess patients properly using evidence-based interventions tailored to history and cervical length. Engage in shared decision making. Promote awareness so that all of us, and that's what we're trying to do here, so all of us are aware that progesterone alone applied vaginally also reduces the risk of preterm birth. So advocate for access to effective interventions for at-risk populations. So basically speaking, we should collaborate with policymakers to ensure availability and accessibility of validated interventions, advocate for public health programs, and together we can strengthen and prevent preterm birth and reduce its global burden through evidence-based care, collaboration, and intervention. I thank you for listening.
Thank you very much. We have just listened to Professor Oluwarotimi talking on vaginal progesterone in preventing preterm birth. He started by classifying preterm births, went ahead to talk about the causes, honing down on the role of obstetrician to prevent preterm birth. He went ahead to talk about the statistics and said emphatically that 15.9% of live births of preterm births occur in Nigeria. And this has been shown to be showing some increasing trends. He went ahead to talk about preterm births and liken it to a syndrome. Told us the component of those syndrome. He went ahead to talk about the triggers before going into, in preventing preterm birth. We shall entertain 2 questions for him. Any question or comment? Just 2. Oh, okay. Who will give us? Professor Adima, yeah.
Thank you very much, Prof. Akinola, for your beautiful presentation. I wonder why the FDA withdrew the use of 17-alpha progesterone caprate. Don't you think that prescribing progesterone alone could be defective in the light of the fact, deceptive, not defective, deceptive, in the light of the fact that you had identified multiple possible causes? I know that, yes, we use 17-alpha progesterone caprate in the management of luteal phase deficiency as a cause of abortion. And having identified multiple causes, would it not be better to tackle the cause itself and then deal with the contractile process the basis on which we use, for instance, beta mimetics, like Ventolin. My main question, don't you think that asking us to prescribe progesterone solely could be deceptive and could be neither here nor there? It could work or it could not work. Perhaps the basis on which the FDA withdrew the injectable. Thank you.
Thank you, Professor Abela, for your presentation. Actually, it's not only the FDA that withdrew the use of 700 progesterone. Actually, the European Union recently withdrew its use. Not only FDA, but recently European Union withdrew the use of 70 alpha progesterone. And actually, what was found out, maybe I was a congenital anomaly, those who use the thing compared to those who do not. Thank you.
Thank you, Prof. A very wonderful presentation. My name is Maureen Umakewulu. My question is about the trial you mentioned. I noticed that most of the pharmaceutical companies doing trials, they do it in Europe countries, then they bring it to we Africans to consume. And even the issue of trial on lung cancer have shown that there is a difference between European and us, because one of their trials worked very well over there, but when they moved the drug to Africa, it didn't work. It shows different ingenuity in any drug trial. Now we are at the stage of drug diversity and trial diversity and inclusivity, sir. You are the part Sogon. What and what effort are we putting on to make sure that these big pharmaceutical giants are including us in trial? As of the last statistics, it shows that only 4% of all the trials carried out, only 4 were Africans were included. So what are we doing at Sogon, as our elders, as the icons we have in medical field, to make sure that we are included in drug trials, instead of being used as a guinea pig that we are not tried, but we are just to consume? Thank you.
Thank you very much. Past President Adima, thank you very much for your question. Yes, just like Professor Aboyeji said, it's not only FDA, because this is 2023. It was concurrent withdrawal of McKenna in both countries. And it is simply, it's a syndrome. You said the symptoms are many. And so you and I know, for example, that we use tocolytics, like you said, beta mimetics. But then suddenly, because of the complications that you associated with it, people migrated to using nifedipine, and that's the drug of choice. So basically speaking, because trials are going on, we keep amassing evidence. So it's actually evidence that dictates what is done. All those trials that were done actually also validated McKenna. American College still does not withhold, would not, and their opinion is actually that they didn't think that they will stop using McKenna. But if FDA said don't use, then you cannot use it. It will not even be available. But there are people who had been using. So what they actually said there, and I think is in one of those slides, there is more need for research into effectiveness of that drug, and then again side effects that it could cause. Because the general opinion is that progesterone, particularly if you are talking about simple progesterone, not androgenic progestogens that are derived from androgens, those are the ones that could be luteolytic. Those are the ones that actually could cause congenital malformation. They can also androgenize fetus. But the truth, if you are using about simple, straightforward progestogens, that they are actually, they support the endometrium, they support the intrauterine environment, and then they make the uterus quiescent. And that's why they are used. So if nobody is saying that only one drug that would be used. The point is that if it's infection, it stands to reason that you want the uterus to relax while you are dealing with the infection. All you want to do is to get the fetus to be viable. Now, I think that Professor Aboyeji also just supported me in that regard. Maureen, I really do not know. So the last I knew was that a lot of giant pharmaceutical companies were leaving Nigeria for economic reasons and all that. Yes, the market is there. You're talking about trials. It is funds. It is funds. One, are we committing them enough? We have the market. So if they are really committed and we are really submitting for trials, I'm sure they will. And some of us have put pressure on them from time to time.
Professor Akiola, we need to thank you because of some other programs.
I was only talking about NICE guideline. I talked about the American College. I didn't talk about Sogon guideline. Thank you.
Well, thank you very much. Can we give him a round of applause, please? That was a nice. So we've come to the end of this session.
Thank you very much, sir. We have a quick presentation. Yes, this is Source Farm to introduce Prog gel, progesterone gel. Are you here?
Prog tablets. Please, you have 5 minutes.
We're taking a photograph. Where are the photographers?
Please, you have only 5 minutes.
I understand you have a flight to catch.
Yes,
please.
He has 5 minutes. Please.
5 minutes. I don't see the photographer. Photographer. What's the name of the place?
Thank you. So you have 5 minutes, please. Just go ahead. The time starts now.
Good afternoon, ladies and gentlemen, dignitaries at the high table, and all the delegates of Shogun. I really appreciate for providing this opportunity to highlight some of the products we have in our portfolio. My name is Mustafa Ali Ariwala. I am a pharmacist by profession, so Pharmacist Ali by short. I represent Source Pharma Nigeria Limited as a country manager. I would just like to brief 1 minute about our company profile. Next slide, please. We are basically a 20-year-old organization. We are one of the largest pharmaceutical manufacturers in India, and we are basically specialized in contract manufacturing for all multinational companies. So all multinational companies like Ferring, Abbott, Novartis, Glaxo, their products we are manufacturing, and today we are proud to present some of those similar brands in Nigeria. Apart from that, we are, next slide please madam. These are the companies which produce for, basically we are contract manufacturers. Next slide please. I am saying we are the largest pharmaceutical companies, means we have 15 factories, and one of the dedicated factories for hormones. We are the second largest producer of hormones in the world and largest in Asia. Next slide please. We are currently present in around 60 countries with our brands. Next slide please. So our key strength is that we have more than 4,500 formulations. We have a robust R&D facility. So our quality of products are as good as multinational companies' product. 3 of our plants are European Union approved, so you can understand the quality we are producing. For today's product, next slide please. Now, to conquer the dream of motherhood, the product which I wanted to highlight for today's presentation on the limited time, thank you very much given to us. Our product is Unoprog gel. For the first time in Nigeria, we are providing a pre-filled vaginal syringe with Unoprog gel, which is natural micronized progesterone, 8%. This basically, I'm sure the indication is for IVF procedure, sustaining the pregnancy, the luteal phase, sustaining the luteal phase deficiency of progesterone. This is one of the best application. There are a lot of clinical trials being conducted, which shows that it is higher efficacy, better pregnancy rate, better fertility rate compared to the capsules or soft gelatin capsules used for that. So we present Unoprog. We also have Unoproc soft gelatin capsule, which is 200 milligram. One of the biggest advantage with this Unoproc 200 milligram capsule is that it is a multi-route capsule. Implies that it can be given vaginal, oral or rectally. Most of the products available in the market are only vaginal insert. As a clinician, I'm sure you must be facing challenge that patients' compliance with vaginal application is very low. So we have Unoproc capsule, soft gelatin capsule available here also at the stall, which is multi-route and it is natural micronized progesterone. Next slide please. We also have in the complete range, we have Unoproc injection also available. So among progesterone, we have progesterone injection, progesterone vaginal gel and progesterone soft gelatin capsules. Next slide please. We also have a blood tonic called Unofervid. It is not a usual formulation. It contains sodium ferritate as a iron salt, which is much more safer. No discoloration of teeth, no stomach upset, and cyanocobalamin and folic acid, which is required for pregnancy and lactation. So please recommend Unofervid Plus. Next slide, please. I believe there are some discussions in the forum regarding the tranexamic acid. One of the Dr. Gaya from Kano presented that they have gotten tranexamic acid as an essential drug. So we have Unotation, our brand of tranexamic acid tablet, and we have tranexamic acid injection also. So Unotation tablet 500 milligram is available. Next slide please. And Unotation injection is also available. Next slide please. So we have both tranexamic acid in the tablet form 500 milligram and tranexamic acid injection is also available. Next slide please. Another product we want to just highlight what about Damphos, a brand of clindamycin plus clotrimazole for vaginal insert for mixed infections. And next slide please. And we have one more very exclusive antibiotic called Tazogard, which is a combination of piperacillin plus tazobactam. I'm sure there is a lot of resistance cases in post-operative cases, especially in gynecological surgeries also. This piperacillin plus tazobactam combination has given better results compared to other antibiotics. I'm sure you will understand the importance of resistance during the nosocomial infections. Next slide please. Next slide please. And the last brand today for presentation in this forum is Acurose, a brand of iron sucrose. Those who are not responding on oral therapy of iron, we have iron sucrose also. So that's a brief presentation of my products. I will request the forum to consider our major brand in progesterone. I'm sure a lot of discussion has happened on scientific side on role of progesterone in maintaining the pregnancy. So we have now progesterone gel, progesterone soft gelatin capsule and progesterone injection also. So thank you very much sir. If you have any short queries would like to address, or we can meet us on this stall and advise us. Thank you very much for giving this opportunity sir.
Thank you, Unisource, for keeping to time, and thank you for being a partner. We appreciate your partnership with Shogun. Thank you very much. We will now move straight into the next session, the Jopaigo presentation. Please, this session, Dr. Oyetunji Jayola, Dr. Victor Abiola Adekoju, and we have also the following panelists: Dr. Aisha Adamunana, Dr. Saidu Abdul Hadi Dio, Dr. Victor Abiola Adekoju. Please, I want to crave your indulgence. We are so much behind time. I know that your session said 1 hour, but please, can you kindly do us a favor of doing it in 30 minutes so we can take other sessions? We really, really appeal to you. We appreciate Jopaigo has been one of our premium sponsors and supporters for this, and we totally appreciate you. So please, we are begging that you would please keep this session within 30 minutes. Thank you very much.
Good afternoon, distinguished ladies and gentlemen. So, as it has been said, we have this session, is a panel discussion. Sorry, Ms. Olayinka, is not this one, the other one, the first presentation. So this panel discussion is, the sub-theme is accelerating the progress towards attaining SDG 3.1 by 2030. And the main objective is to share experiences on the ongoing efforts towards accelerating progress towards attaining SDG 3.1 by 2030. The panelists in this session include Dr. Aisha Nana Adamu, PhD. Please come forward. She's Assistant Secretary General of SOGON and a national PPH champion. Also to join her is Dr. Victor Adepoju. Please come up. He's a Senior Technical Lead for the Amplify project at JPIGO. Please come up. Dr. Dio couldn't make it, but in his place we have Mrs. Omobolanle. She's Deputy Director, no, she's Chief Nursing Officer. Chief Nursing Officer from the Safe Motherhood branch of the Federal Ministry of Health. So I'll quickly start. We'll have two presentations that will take to set the stage before we proceed. The first presentation is titled The Road to 2020, the Role of Calibrated DRIP Towards Achieving SDG 3.1 in Nigeria. Please, could you go to the next slide? Next slide. Next slide. So my name is Jayola Oyetunji. I'm its technical lead for maternal newborn health, family planning and reproductive health at JPIGO, which is an affiliate of Johns Hopkins University in Nigeria. So this presentation will be taken using this outline. I think I can say it. So, as an introduction, yes, sorry, Ajianatu Abdullahi, please pardon me. Ajianatu Abdullahi, she's a technical director in JPIGO RMNCH. She's also a panelist. Please come up. Pardon me, please. So, in 2015, United Nations rolled out 17 Sustainable Developmental Goals, which is a global, this is a global phenomenon that is meant to be achieved within 15 years by 2030. And it aims to achieve decent lives for all on a healthy planet by the year 2030. The third goal of this SDG aims to promote the well-being and healthy lives for everyone regardless of age. And the first of this third goal actually focuses on reducing maternal mortality ratio to less than 70 per 100,000 live births globally and in Nigeria. The question is, how did we get to this point? Next, oh, sorry, I'm the one doing it. So, how did we get to this point? The journey actually started at the turn of the millennium in 2020 when the Millennium Developmental Goals were set. The goal at that time was for Nigeria to achieve a reduction in maternal mortality ratio to less than 250 per 100,000 live births. Unfortunately, we couldn't meet that target, but we tried. If we look backward, you'll see that between 1990 to 2003, we had significant reduction in maternal mortality ratio. But from 2008 till date, objectively, using the last NDHS, of 512 by 2018, you will see that we have not made significant improvement. Then 2015 came and the SDG was rolled out. So what we did was to look back and we asked ourselves, what if, as a country, we had started implementing concerted efforts towards reducing only preventable deaths from PPH, from postpartum hemorrhage, which we all know, all of us in this room, we are aware that if we reduce or eliminate maternal death from postpartum hemorrhage, we would be taking care of about 20 to 25% of all maternal deaths. Then we did a modeling that if we have been reducing maternal deaths from PPH alone every year from 2018, where would we be by 2030? And if you look at that graph, you will see that we must have gone below, far below half of the target of the SDG. But can we boldly say that we have been able to do that? I'm sure the answer to all of us is no. And I picked Professor Uja's comment when he said, in passing during his presentation, that we will not be able to achieve the SDG. Yes, that is true. Because we also did another modeling. We have missed 2018. Unfortunately, we don't have the current NDHS data for maternal mortality ratio. But we said, okay, what if the maternal mortality ratio as of today is still 512 per 100,000 live birth? And what if we put in all concerted efforts to ensure that we eliminate maternal deaths, preventive maternal deaths from postpartum hemorrhage from 2025 every year? Where would we be by 2030? And for the modeling, we see that yes, we will miss the target, but within 4 years, we will be able to achieve the MDG. So this simply tells us that if we're able to implement the new WHO guidelines to ensure that every woman giving birth routinely have objective measurements of postpartum blood loss, and we use all other commodities needed to implement the emotive bundle, we should be able to achieve the MDG, though a little bit late, but just about 4 years after the MDG. So in conclusion, sorry, this thing is not really going back. Yes. This is the wrong slide you sent to me. Anyway, so in conclusion, as I said, that though we may not be able to meet the SDG by 20, but if we scale up the use of calibrated drips and other underutilized life-saving PPH commodities, we should be able to achieve this laudable objective. So for us to continue with this conversation, I will quickly invite Dr. Victor Adepoju to tell us what JPIGO is doing.
Okay, so thank you very much. Sorry for that delay. So I'm Victor Adepoju, and I work for JPIGO. JPIGO is an university with Sogon, and I'll be taking us through the project named Amplify. Amplify simply means accelerating measuring progress and leverage investment for postpartum hemorrhage impact. And we are excited about this because I think this is one of the very rare projects I will see that is totally dedicated to postpartum hemorrhage. We all know the problems we have on where we are as a country, especially in relation to the SDG 3. Next slide. Okay, I can change from there. So can somebody help me? The slide is not moving. Who is there to help? Sorry, let me just bring out my laptop and present from my laptop. Please, somebody can work on the slide to make sure it's moving. So this project is funded by UNITAID, and for UNITAID, we have some basic process that UNITAID follow. Usually, when you have this kind of product or commodity that is either new or is underutilized, for instance, instable carbetocin, tranexamic acid, calibrated drip, some other product that want to really advocate for their use in this project. UNITAID usually, put some form of catalytic investment into such innovation for country to adopt, learn from it, and be able to scale up, whether through investment from the government of that country or from other mechanisms like Global Fund and any other opportunity in the country. So the project is a corollary or subsequent to the Hemotive trial, which result was disseminated last year around November or December 2023, with compelling evidence around the use of the clinical bundle and then 60% contribution to postpartum hemorrhage. So it was based on the evidence from that project that this project has been awarded. The project started about a year ago in about 4 countries: India, Guinea, DRC, and Kenya. However, this is just an expansion into 2 additional countries, which is Nigeria and Zambia. So for this project, we are looking at about 3 commodities that are underutilized. The first one is instable carbetocin, which is very stable. We know the problem of oxytocin, the cold chain requirements, and all that. We know these are not really new products. Essentially, they are products that have been available over a while, but has not been well utilized. So they are underutilized products. The second one is tranexamic acid, which is for the treatment of postpartum hemorrhage, and also calibrated drips. We know that in most cases in our practices, most time we use subjective estimates for estimating blood for women that have been diagnosed with PPH. So now we are advocating for the use of calibrated drip. In other words, 1 woman, 1 calibrated drip. And for this project also, we'll be looking at misoprostol, especially in the advanced use context. Nigeria has several guidelines on advanced use of misoprostol over the years. There are some pilot projects, especially in the northern part of the country, that demonstrated the benefit of advanced use of misoprostol, in which pregnant women are given misoprostol, whether during their antenatal visits or by community healthcare workers, so that when they are in labor, after delivery, they can take this misoprostol. But there have been challenges around scale-up and continuity of this protocol in Nigeria. So we want to understand the barriers and facilitators around the advanced use of misoprostol in at-home delivery setting. So just what I've just said, the current slide is kind of summarizing that. We are looking at the feasibility and acceptability of introducing instable carbetocin for the prevention of postpartum hemorrhage, the use of calibrated drips for assessment of postpartum blood loss, and tranexamic acid as part of clinical care bundle of postpartum treatment. The second thing, we're also looking at the cost, the budget impact of these interventions. And the last one, like I said, is to also look at the barriers, facilitators for advanced use of misoprostol for prevention of postpartum hemorrhage in deliveries that happen at home. I want to take a quick moment, the next slide, to talk about the calibrated drip. This is a very important intervention that can save lives of women all over the country. And as a project, we are advocating for the use of this drip. This drip is now available locally. It's being manufactured in Kano State. And as a project, we'll be using that in both Ondo State and Kebbi State where this intervention will happen. And we're also advocating for us as practitioners, as specialists, to begin to adopt the use of calibrated drips in our various practices, wherever we might be practicing. So this project, one of the goals is to also create an enabling environment. We need policy, we need the product to be affordable for practitioners to adopt it. We need people to be trained, healthcare workers need to be trained on some of these products and the right indication for its use. These are some of the things that is going to happen in the course of this project. And of course, our work with Shogun is also going to address the advocacy area. We know we need to create awareness for people to be aware, both on the supply side and the demand side. In other words, the consumers, which are the pregnant women themselves, they need to be aware of it and be able to demand for these services from practitioners. The practitioners need to be able to use the other policy requirements for being able to use it. So these are some of the things that we are working closely with Shogun to be able to do. Already the advocacy brief has been developed. We have a champion in person of Dr. Aisha that will be doing that, driving that across board, whether with the Ministry of Health, the other professional groups, for instance, the nurses, the parliamentarians, other decision makers and policy makers that are politicians, that are really big stakeholders to make this to happen across the country. Of course, we need a budget. We need government to be able to budget for this. This project is happening in Ondo State and Kebbi State, but we know that the burden is more. There are other states in the country that are in need of this. So expansion, scalability, and replication of this intervention across all the 36 states of the country will be very necessary. And for us to achieve it, we need advocacy, we need to talk to politicians, we need to talk to decision makers, we need to talk to state government to put this commodity part of their state operational plan as part of their annual budget process. So like I said, this intervention is across 2 states, about 25 health facilities across Ondo State and Kebbi State. These facilities include tertiary health facilities, secondary and primary health care facilities. We're also going to be leveraging our existing system, some of the maternal and child health systems that already exist in the country, labor room maternity staff on the use of E-stable carbetocin for prevention of PPH, as well as TXA for the treatment of PPH. We want to be able to treat them on the E-motive bundle to be able to detect PPH very early and be able to respond by providing the bundles. These are things that we are already doing, but this time around, we want to, WHO is of diagnosis of postpartum hemorrhage. So there's clinical component to this work. There is transformational learning, a lot of data used for decision making, human-centered design that will be listening to the consumer, the end users, and be able to co-creating solutions with them. Of course, a lot of community engagement, advocacy, like I said, with Shogun. We had a pre-conference yesterday on the E-motive bundle, and we have a lot of participants, over 20 participants were in that session. We also have another session on labor care guide. So these are some of the collaboration that we are having with Shogun during this conference. So on a final note, my final slide talks about the timeline. This project started June 2024, and we are looking at June 2026 to be able to finalize this. And like I said, it's a mix of implementation, and we're also answering some implementation research questions along the line. There will be 6 months of implementation. All these facilities, we have access to calibrated drips and the other 2 medications, and we are going to implement for 6 months, and the research will start after that. So thank you very much. I think I will stop for now. Thank you.
So thank you very much, Dr. Adepoju. So we quickly go just to expatiate on what we are currently doing and how we can really achieve this goal of the SDG if not exactly at 2030, but at least, not too far away from 2030. So to start with, I would like to ask Dr. Aisha Nana, PhD, what is a calibrated drip and what is it used for? Thank you.
Thank you very much. I have to stand up for this? Okay, thank you very much. So the calibrated drip is one of the, I would say, commodities, things that are used, the management of postpartum delivered, so that you can quickly and easily and more accurately diagnose postpartum hemorrhage without delay. So it's, I don't know, there's a picture somewhere, Olainka, if you can bring it up. So yeah, so that's what the calibrated drip is all about, and is used to detect recommendations by the 2023 WHO laws. Is getting to that level, you would know, looking at it straight away, you would know that basically yellow, which is the alert line, meaning that it's 300 mils. So if you look for one or two other warning signs with 300 mils, you already can trigger off the bundle of care. So I think these are the new things about the drip, that it has to be used routinely, that it's calibrated, and then it has an alert line that will give you a warning, that you don't have to wait for the 500 mils mark.
All right, thank you, Dr. Aisha Nana. I think you have even answered some of the questions that I wanted to ask. But Ajia Anatu Abdullahi, do you have anything to add about when and how these calibrated drips should be used?
Okay, thank you very much, Dr. Jael. Second stage of labor, the drip should be put under the buttocks of the woman, and you have to, the drip has to be lower than where the woman is so that the blood can flow. But maybe this is something that can be researched to see if it can.
Bolanle, you too, you are a trainer, you are a champion from the Federal Ministry of Health, and I believe you have experience. So how easy is the calibrated drip easy to use from your own experience?
Thank you, Dr. Jayola. It's very easy and convenient. It's just like as she has explained, you lay it on the. So to me, I think it's easy and there's no problem about using it.
They might be thinking that, oh, how would you maneuver this and all that? What is that key word that you want to tell them from your experience to make it easy? Because I remember there was a training we had at TOT, and there was some, discussion about how easy it would be from your training, from the experience. Maybe Dr. Aisha want to chip in.
So we did the training and we also implemented. It's very easy to use. Once it's available, it's easy to use, but it's just that sometimes the care providers get carried away, so they must have it ready and it must be tied around the woman. At the end of delivered, that's the beginning of third stage, you now unroll it or unfold it from beneath the mother's, parturient's bum, so that whatever flows out.
After delivery, you are now looking for it. It's already there, it's straightforward once you follow the steps. Dr. Victor Adepoju, calibrated drapes, is it reusable? If yes, how many times can it be used?
Yeah, so we don't want to reuse it. So that's why we say one drape, one woman. So the ones that we have now is not reusable and it's non-biodegradable. However, we are also being proactive because also we are conscious of infection prevention and control. We are conscious of waste disposal management and all those other issues. So the local manufacturer that we have in Nigeria based in Kano, we have also gotten that commitment from them that even though they are starting with non-biodegradable right now, by the middle of next year, they have a plan to transition. However, what we have right now has to be used only once. and after that use, that to be disposed. There is nothing like washing it or reusing it and all that. Once it's used, it's disposed, preferably through incineration and all that. Thank you.
All right, thanks. But before you leave, before you hand over the mic, don't you think that adding, one of the things that has been driving our women away from the facility is the cost. Now we are adding another cost. My first question is, what is the cost implication of this drip, and how do you think it will, the impacts on the utilization of facility for delivery?
So right now, I just confirmed this morning, the unit cost right now is around 2,000 naira. So you are quite right. Cost is a major problem in many rural facilities. For women to even pay 500 naira or something as 200 naira for some items is difficult. But what I think is also that there's no cost to pay for life. And part of what we are advocating for is to make calibrated drip education as part of our antenatal education program. So it's not when women come to labor or delivery, they get to know that they have to pay for calibrated drip. That conversation has to start very early in antenatal clinic. Women need to be educated on calibrated drip, its availability, the cost, the benefit of its use during delivery. I think these are some of the things that we also anticipate that over the years, the cost of calibrated drip will come down. You know that the way manufacturers work, they work on volume guarantee. The more you request, the more thousands of requests that you have, the cheaper the product. And that is the way to go. And that's what we're also engaging the ministry to do. And any other person that wants to engage the manufacturer. Once they have that volume guarantee, the price definitely will cut down by more than 50%. Thank you.
Okay, sorry, before you hand over the mic, you said there's a manufacturer in Kano. Is there any other place where you have a manufacturer? And if yes, how can this be accessed for those that are interested and listening to us?
Okay, so thank you very much. So we have currently 2 manufacturers in the country. There is one in Kano, and there is another one in Oyo State, Ibadan. We have confirmed that the Kano plant is currently actively manufacturing, and their throughput is about 1,000 per day, and they want to double or even triple that before the end of the year. The one in Ibadan is also in process. They have not started manufacturing right now, but very soon they're also going to start manufacturing. You can get it either like a program like us that we got it directly from them. Individual can also approach them and get it. Even hospitals can do that. And if anybody needs their contact, we're also happy to provide it. Thank you.
Okay, so they can see you at the Jepaigo desk, at the booths there.
Definitely.
For contacts.
Definitely.
Sorry, ma. You have answers to that. Okay, Mrs. FMOH has additional.
Yes, because we have their contacts, and in every state we have Safe Model Coordinator. So we send their contacts on the platform of Safe Model Coordinator so that they can easily access them and make demand for supply. Thank you.
Okay, thanks for that. So for those of you listening to us, you can reach out to your Safe Model Coordinator. Every state has a Safe Model Coordinator, and they have all their contacts. Before we wrap up, Mrs. Omobolanle, what is government's role in ensuring that this calibrated drip is widely available, accessible, and affordable? What is government doing?
Yes, presently, we've sent letter to all state commissioners in all the 6 states plus FCT in the role of scaling up and use of calibrated tape. And in this, government has always said that it should be locally produced, and they are ready to support any local producer so that the cost will be at not a exorbitant cost. So government is willing to support.
So there's government buying, and if you remember in my presentation, there was a photograph where the coordinating minister himself launched the calibrated drape in April 2024
during our Safe Motherhood Day. And he made it compulsory that drape should be part of delivery kit of a woman.
Okay, all right. Since we have government backing, I'm sure it will work. Let's quickly go back to Dr. Adepoju. Your project, Amplify project, what role are you playing to support government to ensure that calibrated drapes, and in fact, other commodities that are required to prevent and manage postpartum hemorrhage are easily available, accessible, and affordable?
Okay, so thank you very much. So I would say our role with government is both on the supply side and as well as on the demand side. So on the supply side, we do know that for this to work, some of these commodities, for it to really be mainstream into our health systems, a lot of things need to happen. So the first thing is that we need to, the price has to come down. The price of this commodity, price is an issue. So for that, we are working closely with manufacturers of these commodities, the pharmaceutical company, to be able to have some negotiated price with them based on the market environment and the demand for. We're also trying to create awareness so that when the consumers are aware of it, there will be increasing demand, and it will be easier for the manufacturer to bring down the product.
All right, thank you. So before we wrap up, just one question each. Mrs. Mobalanle, what is your recommendation to government to scale up the use of calibrated drip?
Just like I have said, the government have written to all the commissioners that it is compulsory. Every woman in labor must use calibrated drip. And my advice now is to the states that they should implement what the government have said. Thank you.
Dr. Aisha, what's your recommendation to clinicians who are yet to start using calibrated drips?
Well, I think clinicians would not have any problem with using calibrated drips. The challenge now is making it available. Once it's available in our health facilities and labor wards, clinicians will have no problem with that. But I mean, this is a body of obstetricians and gynecologists. They are the leaders as far as maternity care is concerned. So, and they are all listening that this is a new WHO recommendation, and we are the ones that will uphold these guidelines when they come. We're the ones that will implement and put to practice. So the call to the clinicians will be to try and also implement this guideline. Once the drips are available, we should encourage and mentor the younger ones and supervise our midwives in labor wards to see that every woman gets one.
All right, thank you. Finally, Aisha Anatu, your recommendation to the women giving birth.
Okay, so my recommendation to the women, we know that the woman may have to be on the drip for 1 hour at least after delivery. So the recommendation is not just for the women, but also for the service providers, because they had to educate the woman on the importance of being on the drip for at least 1 week for 1 hour for observation, because I think during interventions, some of the challenges were that women resist staying on the drip after they deliver. They immediately want to go off. So they need to be educated so that they know that they need to stay.
Sorry, this one is a Jara question. Okay. Especially since you are a family planning provider, also expert, when would you recommend that the counseling of women on calibrated drip should commence?
It should commence during ANC.
Excellent. So it's not when the woman is in labor you start telling her about calibrated drip.
During
we should
ANC.
start the counseling just as we do for family planning, postpartum family planning. We should start it during ANC, so that not when they come to labor room they are just seeing this for the first time. Thank you very much for participating. Thank you for your audience, and that's the end of this session.
Thank you so much. Another round of applause for Jopaigo.
Oh, picture, yes, let's take a picture.
Please. Can you step up and then, Mr. President, sir. Mr. President, sir, please can you join them for the picture? Thank you. Thank you. Lunch is almost ready to be served, but we can do one quick session before lunch, seeing that we had a late tea break. So I would like to call on stage the next session, which is mitigating gender-based violence. The presenter here is, the chairman of the occasion is Professor Mabel Ecott. Please, can you come up? The co-chairman is Professor Jeremiah Israel. Is he around? While the rapporteur is Dr. Tubabasi. Dr. Tubabasi. Now, the presenter is our own very erudite M1 president, Professor Rosemary Ogu, but I'm told she has stepped out and she'll be represented for this presentation. Please, can the presenter come up? Please, to save time, we have 20 minutes for this session. Thank you. So, presenter, please introduce yourself, and then you have the floor. Thank you. We have 20 minutes for this session, so you should be able to do in 10 minutes. Thank you.
Thank you very much. Good evening, our dear Sogon President and Executive, professors here, senior colleagues and colleagues. My name is Dr. Veti Agala. I'm not an obstetrician gynecologist. I'm a public health physician and the national coordinator for the Medical Women's Association of Nigeria. I also double as the executive secretary of the River State Health Insurance Agency. This evening, in the next few minutes, hopefully, I will try to fit into the shoes of the psychedelic, very elegant national president of the Medical Women's Association of Nigeria, Professor Rosemary Ogu, who is supposed to be speaking on mitigating gender-based violence in Nigeria, a call for action. And so the outline is like so. So there'll be a brief overview. We'll look at the root causes. We'll look at the impact of GBV on women and children, and then the current policy landscape. And of course, we'll look at the call for action. So as overview, I'm sure just as our dear keynote speaker said, there's really nothing that we are saying here that most of us don't know or haven't heard before. And so we know that gender-based violence is something very prevalent, and it is pervasive. It's something that is so common that is becoming epidemic. It's becoming an epidemic, and we are told that 1 in 3 women globally, and even in Nigeria, studies have shown that 1 in 3 women have gone through one form of sexual or gender-based violence or the other. But when we talk about gender-based violence, of course, it's not just a women thing. It's just because it is more prevalent in women, and that's why it seems like it's violence against women and girls. And so it is gender-based violence because it is violence perpetrated on people because of their gender. So whether it is the male gender or female gender at any point in time, that's gender-based violence. And it could be physical, it could be psychological, it could be economic, it could be harmful traditional practices such like, as female genital courting, or harmful widowhood practices, or early marriages, you name them, and I'm sure we know them. And we look at the causes and the risk factors. Cultural factors. We are in a patriarchal society where the male gender is held supreme, and there are so many cultural narratives and discrimination that put the women and girls at risk of having a higher prevalence of gender-based violence. Economic dependence. A lot of women and children, of course, are dependent on the men, the fathers, the uncles, the brothers, and so that places them in a position where they have to go through different forms of violence. We've had women who would not just step aside or leave because they need the man to feed them, they need the man to provide shelter, or even to take care of the children's bills. We also have some gender inequality, where women are viewed as inferior to men, and that's for us is the major driver, and that's where we keep talking about gender equity and gender equality. And as most of us know, from the 25th of November to the 10th of December is tagged the 16 days of campaign or activism against gender-based violence. Societal factors such as weak enforcement of our laws. As we would see, there are a lot of laws already that is supposed to help mitigate gender-based violence. But you find that most of those laws are not being implemented or enforced. And so the impact on women and children is so much. One of them is the health impact. Of course, it could be physical injuries, it could be pregnancy, it could be sexually transmitted infections, especially if it's sexual-based violence, depression, anxiety, mental health disorders, or post-traumatic stress syndrome. It could be a disruption in the life of that girl, child, or woman. So perhaps she's in school and then something happens, she has to drop out of school, maybe ensure that she has a baby, or she just becomes sick and gets to leave school. Trauma, we've talked about that. We've talked about a cycle of violence. So you find that those who went through one form of violence or the other, they have children, those children go through that same cycle, and it continues as a generational problem. So I'll just go on to key policies that we have as a country. I know that in 2003, the Child's Right Act was enacted, and at the national level and then at the state levels. I think all states in Nigeria now have the Child's Right Law. That law tends to protect the children, and so there is no under 18 girl that will give you consent. So if you have anything to do with a 17-year-old girl sexually, then that will be that would have been rape. Okay, so that law is there and tries to protect children. And then in 2014 or 2015, we have the Violence Against Persons Prohibition Act and then law, which protects both men and women from different forms of violence. But the challenge is the gap in implementation, which is something that I have mentioned. Many people do not even know that there is a law like that in their states. I recall that in Rivers State about 8 years ago, certain forms of violence like the female genital cutting, which is still prevalent, we found out that there was a law, you know, and then the provisions was that if you were caught, you would pay 100 naira, and then, or you'd be in prison for 2 years. And so when you look at the provisions of the law, you find that it doesn't look enforceable, and it looks like it's a child's play. So many people don't even know, for one, that there is a law. Some people do not know that certain things comprise or certain behaviors are gender-based violence. So for instance, a woman comes to tell you that it's because her husband loves her. That is why he treats her that way, because he wants her to behave well. Or she gives an excuse for herself to say, I behave this way and that's why he hits me. And so we make excuses because we don't even know that even in marriage, there can be intimate partner violence and all of that. So those are some of the narratives that we have at the moment. So these also lead to the barriers that we have, whether it is societal stigma. People cannot talk about their valuations. Up until 2015, 2016, many people would not report any form of violence because you go to the police and they tell you is a family matter, or what were you wearing? How come he raped you? I'm sure you were not properly dressed, or why are you dressed like this or that? So stigma, the fear of blaming. You blame the victim, and that's a problem. Ostracization, from their communities. And these are the things that make women and men, even boys, they say, you are a man, why are you crying? Or you come to report a case of GBV, and they say, a whole man like you, your wife beats you, those kinds of things. So they won't come up to report. And then even when they report, we don't have the resources to manage. We don't have the resources in place to ensure that survivors can have the needed health care, can have the legal aid that they need, can have shelters. So where will a woman go to if she's being violated against? Or even a young boy that is being mistreated in a home, where does he go to? So he keeps staying where he is or she is because we don't have enough resources for survivors to benefit from. And that can be a problem. Of course, everything we're doing is deeply rooted in our culture and in our traditions. And these have been entrenched, even in our upbringing. So you find that women are also perpetrators, and we feel perpetrating gender-based violence. We treat our girl children differently from the boys. We tell the girls, sit at home, make sure that you're in the kitchen, sweep the house, but the boys can go out and play football or be on their games. So when we raise the girls well, and then we have boys who may not have been well raised, there will always be violence in our homes, whether you are fully or very highly educated or not. And so you find that gender-based violence cuts across the rich, the poor, the young, the old, children, adults, very highly educated, and those who don't have even formal education. So what is our approach? It has to be collaborative. It has to be multi-sectoral. Everyone must put their hands on the plow, from the individual to the household, to communities, to NGOs, CSOs, to the government. Everyone must have a part that they play in mitigating gender-based violence. But we are health sector players. We are obstetrician gynecologists. We're doctors. And so, first of all, we need to have high index of suspicion. Sometimes a woman comes to you, she has these headaches, and there's nothing else is wrong, but she keeps coming back every week, every 2 weeks she comes to you. You need to begin to ask. For us in public health, we are very concerned about the family and social history. So once you have a high index of suspicion, you will be able to do something about that. Another thing we can do is to ensure that our policies make provision for access to health care when violence is perpetrated. Sorry, this is not moving again. Okay? All right. We need to engage the education sector. And so what is our role? Government has their role. They put the laws in place. They put the different sectors in place, and to ensure that different people are engaged to mitigate gender-based violence. The legal people have their role to ensure that perpetrators are brought to book. Education sector, this is one sector that we need to do something about because awareness is so important. And I've talked about the health sector. Doctors, healthcare providers need to be trained. How do you report a GBV case, especially maybe when it's a rape case? Because that is a document that will be tendered in court. Do you know what to look out for? Do you know how to advise people? Maybe during antenatal talks, do you tell them what to do if they go through one form of violence or the other? Do we have the survivor mapping? Do you know who, the police, DPO, where you work? Who can you call? Do you have the contacts of the legal aid? So all of these are important, and we have a lot of technological advancements to use. And so people can report. They don't need to report face-to-face. They can report via apps. They can reach out to us and access healthcare in different forms. Women need to be empowered, not just educated, but actually empowered. Because when you're empowered, then you have a voice. Then you're not intimidated. Then you can step aside. Nobody says you should leave marriage or leave a relationship, but you can step aside for a period, because it's only a live person that can maintain a relationship. So there's a lot of work going on. Medical Women Feeder, the Mirabel Center in Lagos, and so many other places are doing a lot of work to mitigate gender-based violence. And key activity that we want everyone to carry around is get aware, get the requisite knowledge that you need. We'll train health workers and then continue to advocate. We want to raise his for she's. The Deputy Governor speaking earlier in the day looked at the high table and saw just one female or so. And, so let's have more women rise up to leadership roles. And I'll just go to the last. I think I'm almost done. Yeah? The last, yeah. So in the short term, what can we do? And I've said that. We can increase public awareness. We can engage communities, train healthcare providers, doctors, nurses, have a high index of suspicion, report. When we report, we get to know the magnitude of the problem. This is a tip of the iceberg, this 1 in 3, because a lot of people are still not reporting. We did a study sometime in 2016, and we saw that it is the people that women and girls trust that are perpetrating violence against them. So it's an abuse of trust when fathers and uncles and family members and bosses are the ones that are perpetrating violence against our women and girls. So in the midterm, we need to expand shelters, legal services, ensure that the litigation process, is not too long. People get weary of, going to court today, tomorrow, and before you know, they get tired of coming back and forth. So they decide that nothing will happen if they report, and so they are not reporting. So in conclusion, I would like to read what she wrote here. She says, gender-based violence is a flagrant violation of human rights that undermines the health, the well-being, dignity, and dignity of women and girls. It is a complex, multifaceted issue that demands a comprehensive, multi-sectoral approach involving the government, healthcare professionals, community leaders, and civil society. By fostering an environment where survivors are protected, perpetrators are held accountable, and cultural norms evolve to support gender equality and mutual respect, we can build a safer, more just Nigeria. It is a collaborative responsibility to champion this cause and ensure that every individual is free from the scourge of violence. So join us, and this is a call to action. Join us to advocate. Join us to be more critical when looking at the next woman. Don't just look at her abdomen or the pregnancy and the baby. Ask other questions. There may be a mark somewhere that shows that is a telltale sign that she is being abused. Advocate for change and raise awareness anywhere you are. So thank you very much for your time.
Thank you. Can we put a round of applause for the presenter? In the past 20 minutes, we have been, she has talked about how we can mitigate gender-based violence. And we'll allow our chairman to speak before we take some questions and comments.
Thank you very much. Thank you, Dr. Betty, the President of SOGON, council members, distinguished elders. I want to thank SOGON and the LOC for this opportunity for us to discuss this. This is very apt because this month, as she had said, is a month set aside to draw the world's attention to gender-based violence. Gender-based violence, as Dr. Betty has spoken in, who represented Professor Ogo, it is cross-cutting. It does not spare anybody. I am so sure that if we do a survey, a very confidential survey in this room, and say who has been a victim of gender violence since she was born, we'll have maybe about 30% of people admitting to that, including men. It has caused a lot of problems, and I thank God because women were asked to bear and bear and bear until the musician died, and people now said, no, it is not cancer that killed her, but gender-based violence. And that has freed women. The pastors are now talking about gender-based violence, saying speak out, and that is what we are doing here. And during this period, people, the presenter has talked about gender-based violence affecting everybody, but women and children are more affected. 30% of women in their lifetime will experience gender-based violence. And it is often shrouded in secrecy. Nobody wants to talk about it. She has gone ahead to talk about the factors that enable gender-based violence, cultural factors, religious factors, socioeconomic factors, and the society condoning gender-based violence. Once a woman's bride price has been paid, she has become a property, she has no voice. Whatever is done to her, she's supposed to tolerate it. Those are things that enable gender-based violence. And, and moreover, even the victims are shamed when they go to report. There is no excuse for gender-based violence. The woman is accused of dressing in a provocative way. Why was the skirt too short? That was why. Why was she outside by 7 o'clock and not behind the gates? So there are laws. Child Rights Act protects children against childhood marriage, child marriage, but we are seeing them happen and nothing is happening. We are also made aware that there is Violence Against Persons Prohibition Act, but the punishment is a child's play who cannot pay 100 naira and get out of it. And then barrier, stigma, people are ashamed of talking about it. And then, so what are we supposed to do? We should collaborate, speak out. Doctors should be trained to identify victims, and they should know actions to take when they see a woman who has been abused. But one thing I have notice about gender-based violence is that the victims themselves are not really ready to pursue the actions. In this very state, there was a social media video where a pharmacist was beaten up by a husband who was a lawyer, and the neighbors got so upset that they videoed it, shared it on social media. The Pharmaceutical Society spoke, people spoke, Women Affairs spoke, but it's that same woman who called a press conference and said they should leave her husband alone. So the women themselves need to be trained to be able to speak up for themselves and to take actions when they are victimized. So on that note, I would like, we would like to take 2 or 3 questions on this gender-based violence. Thank you very much. 2 or 3 questions. Any hand? Nobody has contribution to make? Okay. Thank you very much. That's the end of the session. Thanks a lot.
Thank you, Professor Mabel Ecott, and thank you, presenter. Please, you step forward for your picture. Maybe, Buchi, you snap with them. President cannot be coming up every time. Every time, President will. President will stay in the center.
President, you have to be in between from. In between from, Mr. President. What's the name? Who will I report to? Can you go ahead then? We don't have time.
Yeah, ladies and gentlemen, lunch is about to be served, but the lunch, I think we will. Lunch will be in the gallery, so we've asked the food servers to move upstairs so you can have places to sit down and place your plates and eat. So while they are relocating, I want to crave your indulgence. Let's just take a very brief session.
No, they are taking the food off. Let them know that they are taking the food off. Bring the nose back. Talking why the food is off now. Let the next one. Let's follow this. This is the next one. They're not protesting. They're protesting. Let them go and eat. Let them eat. They are going off. They don't protest.
Okay, please, you can go upstairs to have your lunch. Thank you. But we will just 15 minutes. We are running really behind time. 15 minutes. But it was a very late tea break now. Why do they behave like this?
You don't know people are food.
Me, I never
I don't even want to eat anything. Are we staying here? Or it seems everybody's
They're
going
supposed to.
Oyoko.
Dr. Abba, please come up. No,
They're bringing, they should.
Bring food for people.
Yeah. Hold it. Remember my own. After my own presentation. After the lunch, there's a short one before my own. It's our food here so that they know what they're doing.